All right. Good morning, everyone. Welcome to Rounds on December 13th. If I can get the slide to advance, we will start rounds. Okay, there we go. All right, so our first case is the left eye from a 10-year-old pit bull. And I forgot to bring the paperwork with me. Let's just say they said there was blood in the eye. I can't remember what the history was. And then they didn't give us any more medical history. I do remember that. Actually, I lied. They told us that CBC and chest x-rays were within normal limits. So there we go. That's all we know. So we received the globe and we hemisected it, and here it is. So the cornea is always at the top at our photographs. And the lens is here, and so the back of the eye is here. So down here somewhere is the optic nerve head. So we observed a mass that was in sort of the anterior and posterior chamber, kind of wrapped around the lens. Some of it is over here. And then there's quite a bit of hemorrhage in the eye, from what you can tell, all of this red stuff. This area right here is probably an area of high protein serum that sort of turns into a bit of a gel when it is formalin fixed. And then let's see here, it's kind of hard to make out the uvea. So this might be the iris right here. So this is the front of the iris leaflet. It's kind of pale tan. And we can't really see the retina very well. So it's either still attached or it's detached and somewhere in the middle of this. The lens is here and there is a cataract. So that opacity in the lens is consistent with a cataract. So we're really curious what this mass is. So now we will go to this. All right, so this is our subgross view. I know it's a little bit out of focus and wonky, but so here is that mass that is in the anterior and posterior chambers. It has a decent number of blood-filled spaces in it throughout it. So here is the cornea. There's more of just frank blood right there. There's the iris leaflet on this side. It's pretty inapparent on the other side where more of the mass was. And then there's more of that tissue that was kind of tan in the gross photo. When we move back into the posterior segment here, here's the optic nerve head and the optic nerve. Here's the retina that's detached. It's just not sampled in this area. So it's detached. And then there's a lot of blood in the vitreal space and in the subretinal space. So let's go ahead and figure out what kind of mass we have. All right, so we've got a mass. It's pretty densely cellular, except for those sort of blood-filled spaces. At this low mag, we can't really pick up much of a cellular arrangement in those areas of high cellularity. And that holds pretty true as we get higher and higher mag. So there is one of the higher mags. And so maybe you can kind of make out the cells are maybe forming some sort of structures. It's kind of hard to tell even at this mag. So that whatever they're making is not terribly obvious in this area. Let's just go ahead and look higher mag at what they look like. So they are polygonal to maybe spindle shaped. They have mostly indistinct cell borders, but some of these areas, they have more distinct cell borders where you can see where one cell stops and another starts. Their nuclei are pretty pleomorphic. So we've got some that are kind of smaller with more slightly condensed chromatin like this and this. And then we've got some that are larger like this guy here with coarsely clumped chromatin and really prominent nucleoli. So we've got a little bit of cellular and nuclear pleomorphism. Let me take you to another area of the mass on this side of the eye. And then I'll show you in the other side. Wait if I can find my good area. Actually, I'm just going to go over to the other area. So let's look at this over here. So the cells where we were just looking, it's not terribly obvious who they are and what they're doing. But when you come over here and look in this area, those blood-filled spaces are the more prominent feature in this area with fewer cells. And so there are these really nicely collagenous trabeculae. And then the neoplastic cells are lining those collagenous trabeculae. And so in this area, this is a classic vascular endothelial tumor or hemangioma or hemangiosarcoma. And then in some areas, let's see here. Oops, sorry. We get some more pronounced cellular pleomorphism. So this is one giant cell that's probably sloughed into the lumen. He's very large and he's undergoing mitosis. And that's a pretty bizarre mitotic figure. So an abnormal mitotic process happening there. And so this whole tumor, even though it looks very different on the different sides of the globe, is a hemangio something or other. In the eye, so it's a vascular endothelial tumor forming vascular channels. In this area where I started, the cells are more forming solid sheets rather than those nice individual vascular channels. And this feature right here of vascular endothelial tumors is an indication of malignancy. So we would be starting to think that this is a hemangiosarcoma. Mitotic figure count doesn't necessarily play into how we diagnose hemangiosarcomas versus hemangiomas in Coplow. We don't have a set threshold, at least I should say. But these areas of solid growth are in general consistent with a more aggressive malignant endothelial tumor. And then the other major part of this diagnosis of being a hemangiosarcoma is that it's in the eye. And to our knowledge, we don't know, or at least don't commonly encounter primary intraocular vascular tumors. So we assume that this is a metastatic tumor that originated elsewhere in the body. So the most common sites would be the atrium of the heart, the spleen, and the liver. Probably much less commonly would be the skin, because usually the cutaneous vascular endothelial tumors tend to be a little bit more benign and don't metastasize as frequently. So I thought this was just a really interesting one because generally speaking, when we diagnose hemangiosarcomas in the eye that we assume are metastatic, they almost never form these solid areas like this. They're almost always much more vague formation of vascular channels with blood in them. And then you have to look really hard at those cells that are lining the vascular channels and then decide whether we think they're neoplastic versus reactive cells that are just reacting to, for example, to hemorrhage that is in the eye. So those are the main features of this neoplasm in the eye. We can look at the rest. So Descemet's is detached right here. You can see it's all, oops, kind of squiggly. This serpiginous pink thing is Descemet's membrane. It's all detached. The neoplasm has sort of dissected between the corneal stroma and Descemet's membrane and caused separation. The corneal stroma itself is vascularized. That's what we're seeing here is some blood vessels. Oops. I mentioned that the lens was opaque in the gross photo, which is consistent with a cataract. So usually that is some sort of disruption of the lens fibers. So here's our anterior lens capsule. This is what the lens should look like. And then we have this area where the lens fibers are completely liquefied. So that's consistent with cataractus degeneration. And when we move to the back, usually there's also posterior cortical changes. So here's the back of the lens. Here's the posterior lens capsule, which is much thinner than the anterior lens capsule. We've got some degeneration of the lens fibers there. And then, as I mentioned in the our subgross tour, the retina is diffusely detached and a little bit variably atrophied, perhaps. I don't see very many ganglion cells here. But also when you think about a retina that's detached, usually the outer retina will degenerate. And what we're missing here is the inner and outer segments of the photoreceptors. So that's where they would be picking up the photons of light. And then back here, here's the optic nerve head, which is a little bit distorted by the detached retina. In this case, or in a case like this, I should say, when the retina is detached, and the optic nerve is a little bit distorted because of the detached retina. It's sometimes a little bit hard to definitively define or diagnose glaucoma. So often we will just say glaucoma as per history and then specify whether we thought it was primary or secondary. So those are the main features of this case. I just thought it was really interesting because we don't usually see hemangiosarcomas in the eye that look like this. And I thought it was kind of a cool case. So let's go back to our PowerPoint. So the diagnosis was intraocular hemangiosarcoma, metastatic, which is much more likely, versus primary intraocular, which is much less likely. As I said, I can't even ever remember diagnosing definitively a primary intraocular hemangiotumor, an endothelial tumor. So probably this is metastatic. They did say that this dog had normal chest x-rays. So it's possible that either it's a small tumor and they missed it. It hasn't affected the heart enough to be radiographically obvious, or it originated somewhere else like the spleen or the liver. So
we had, and I looked, the only reason I know is because someone asked me that question and I looked at the database. We had 2 or 3 potential hemangiomas of the iris, where there was a benign mass in the iris stroma, well delineated. So, but none that we were very confident were hemangiosarcomas, for all the reasons you just explained.
yeah, that's right. I forgot about those. Yeah, this one, it did efface the uvea on that side of the on that side of the globe, so maybe, but it's definitely not benign looking at all. So
not at all.
Yeah. Okay, cool. And let's see here. I did do a mitotic figure count. There were 21 mitotic figures in 10 high-powered fields, so that's pretty high. Yeah. Okay, cool. So let's move on to the next one. So 2 weeks ago, I brought an eye of a sea turtle, I think a different species than this, if I'm remembering correctly. But anyway, maybe it was a green. Anyway, so that case that I showed 2 weeks ago had a fibropapilloma, which is associated with a herpes virus that affects sea turtles. And that one had some very mild changes of the scleral cartilage. And it sort of tickled my memory about this case, which I thought maybe I would share as well, just because it's so weird. So this is the left eye. Well, I will show you the left eye, but this is from a 22-year-old green sea turtle. And the history we got was, let's see here, intermittent history of bumping into the glass and decor in the enclosure. It's from an aquarium, possibly due to vision deficits. And then the animal died and a necropsy was done. So they said found dead without premonitory signs. I can't remember. I probably did hear the results of the necropsy, but I don't remember what they were. But anyway, so we ended up with one of the eyes. And so I will show you what we have here. So when we hemisected the eyes, these were decalcified prior to sectioning, I think. And then because they have a scleral ossicle, which is true bone at the front of the eye, just like a bird. So we did decalcify them so that we could section them. And then they also have scleral cartilage, which we saw in the case that I showed a couple weeks ago. And then anyway, so we hemisected the eyes. And interestingly, the ocular cavity itself is like a normal shape. It's kind of round at the back. The lens is anteriorly placed. That's normal for a sea turtle. But interestingly, this scleral cartilage back here is really irregular. And you can see the contour is like kind of wavy. And then it's just like this outer contour of the globe is just really weird. And it sort of has a different hues in whatever is going on here. So I thought this was really interesting. I think this is an artifact. So I think the retina is detached there. I can't tell if this is true misshaping of the contour of the inside of the eye or not. I think it's an artifact. And then down here, we've got some retinal detachment. And some of this is probably RPE or maybe some choroid that's peeling off with that retina. And once again, this is a postmortem eye collection. So there's going to be a little bit of autolytic artifact there. Anyway, so we thought this was really interesting. And let me see if I missed anything here. This was probably fixed in Bouwens. At least we have a note here, maybe. so that the cornea will be cloudy in Boone's and the lens will also be a little bit cloudy. Okay. So let's go to the slide. All right, let's see here. So the front of the eye is here. I think this is artifact, the way the cornea kind of bends inward like that. I think in real life, they're probably flat, which is pretty common in sea creatures. It helps with the refractive index of water to be able to see clearly. Anyway, so actually the front of the eye is pretty boring. As we move backwards, here's that scleral ossicle. And then there are some overlapping ones here more anteriorly and superficially. So this has been decalcified. Normally, bone that it has mineral in it still is purple and it doesn't cut very well by a microtome. So there'd be a lot of artifact. But this one was decalcified, which removes that mineral and makes it easier to cut. And then as we move back, we pick up the dark purple of the scleral cartilage here, which is probably more normal shaped here. And then as we move backward, it gets really, really thick and kind of irregular. And there's one portion of it that's really dark and has like a nice smooth contour. And that's probably normal, the normal scleral cartilage. And then as we look inward, here's the choroid here. You can pick up maybe some of the melanin pigment in the pigmented choroid. And then from here to here is that sort of maybe suprachoroidal space. And all of this paler purple stuff or basophilic stuff is also cartilage, but it's a little bit abnormal because of how pale it is. And then as we move back here, more of the same. So it sort of extends out from the inner surface of the scleral cartilage and kind of expands this space. But interestingly, it didn't seem to change the shape of the eye. So even though it seems like it's growing inward, it really didn't change the sort of the posterior segment of the eye, which is actually really important for vision because as soon as you start to distort the contour of the fundus or the back of the eye, that's going to disrupt and make vision abnormal. So let's get a little bit higher mag here. So there's the optic nerve there. And so, and once again, remember that this was a post-mortem sample, so there's some autolysis. The camera might not like this purple. Come on, you can do it. Right, maybe higher mag. Okay, well, there's the area where it was darker purple. It's a little bit lighter purple in this image. As we move inward, so all of this is cartilaginous matrix. And all of these little spaces are lacunae, and in each space there should be a single cell chondrocyte. And then we also have numerous blood vessels going through here. And actually some of this is a little bit of melanin, probably associated with the choroid. So we just have this really exuberant proliferation of the cartilage, of the scleral cartilage, for no known reason. And because it's not necessarily altering the shape of the back of the eye, I don't think that this explains the possible vision abnormalities this animal was experiencing. But maybe it was in some way altering vision.
Yeah, the retina looks good, right? There's no.
Yeah, I mean,
it doesn't look like it's compressing the choroid.
Yeah, right. The choroid is
vascularized.
The choroid is still nice and thick. Once again, this is an autolyzed retina because it's postmortem. But we have beautiful cone photoreceptors there, and probably some rods as well. And so the retina, as far as we can tell, is normal. It's possible maybe that this was maybe compressing the optic nerve somehow. But we didn't really appreciate changes in the optic nerve that we thought were true defects in the optic nerve. So yeah, it's just sort of a mystery. Well, the possible vision abnormalities the animal was having are mysterious. And this interesting scleral cartilage proliferation is also kind of interesting. So yeah, it's sort of a mysterious case. But I thought it was kind of cool. I suspect that this is some sort of aging change. Maybe it's more pronounced in this individual, because remember, it was bilateral, at least based on the gross images. And so we saw little hints of scleral changes in the case that we showed last week or 2 weeks ago. And that animal was 5 or 7 years old or something, from what I remember. So this one's a 22-year-old. So yeah. Anyway, I just thought it was interesting. So, oops. So our diagnosis is kind of waffly and weird, but distortion of the globe due to diffuse but asymmetric expansion of the scleral cartilage inward. But once again, it does maintain the shape of the back of the eye, which means that the vision shouldn't necessarily have been affected. So that's all I have.
Right. Uh, no. Okay. All right. So this is an 8-year-old neutered male French bulldog. The history for this case: mild ophthalmos with hyphema, which prevented examination of intraocular structures. So simple history. The gross image here is actually a representative image. It's not actually the case that we'll look at histologically, but the case we'll look at histologically did not have a gross photo. I grossed it, so that's on me. But anyway, in this sort of representative gross image, we have blood in the eye, but noticeably at the back of the lens here, or in the anterior vitreous, we have this sort of popcorn-like tan white material. And so that is significant. And we'll go to histo. No. Okay, got it. Okay, so the globe's on its side with the cornea over here on our right. And we can already see the hemorrhage in the eye coming into view. So check, blood in the eye. But as we head backwards, we're looking at these levels of the iridocorneal angle. They're very closed up. We don't see the flow holes there that we typically see, similar on that side. And we can show you, nope, we can show you, I'm avoiding, because I'm building a story here, this side as well, which also looks closed up. All right. And when we look closer, man, I think that there's a even better one than this, but there's 2 things that are important to point out. We have iris stroma here, which has these sort of short, choppy, intersecting collagen bundles interspersed with melanocytes, and there's a similar type of tissue that's crossing the angle and directly meeting the endodesmase membrane here. However, notably in this case, at least, while it's not obviously producing sort of peripheral anterior synechia on top of that tissue, there is a fibrovascular membrane forming, and we'll have more discussion on that later. But the main thing here is that there is goniogenesis in this case, which could have contributed to glaucoma. But that's not all. It's a twofer case, as they call it. Now to where I've been avoiding unfairly. Here we go. Nope. There we go. So sort of starting to come into view here, we have these little balls of cells in the vitreous. There we go. That's even better. And they're kind of tracking along degenerate vitreous and forming these interesting little strands, and they're kind of tracking along the retina. So in this case, it didn't really form a ball of cells in the anterior vitreous like it often does, and like that gross photo is representative of. But when we look closer at these cells, they're just these sort of rather bland looking spindle to stellate cells. sort of tracking along degenerate vitreous, and there's sometimes that mixed with a little bit of necrotic debris. So there's those guys. And then I'm going to switch to a deeper section that we have. So here's the cells still here tracking the retina. And when we head back to the optic nerve head, hang on a second, we have some shmoo on that slide. There we go, it's gone. And when we get to focus, there is this sort of delicate little fibrovascular tissue forming on top of the optic nerve head. And oftentimes in these cases, it'll actually form a sort of little fibrovascular protrusion extending from the optic nerve head into the vitreous. But there tends to be this sort of fibrovascular proliferation near the optic nerve in these cases. You may have also pointed out or noticed that the optic nerve head itself next to this is also abnormal. Actually, I should just stay on the magnification I was on. So there's necrosis of this optic nerve head. And we basically have this rarefaction of the parenchyma and keratotic necrotic debris sprinkled around here and there. And then on the edges, there's even some gitter cells. Gitter cells, the macrophages of the central nervous system. So this is a necrotic optic nerve head, which is typically a feature of acute glaucomatous degeneration. But then there's also features of chronic glaucomatous degeneration in this case. The retina over here, for example, has inner atrophy. And usually when we have overlap between features of acute and chronic glaucoma, we call it acute on chronic. It may either be probably either be a subacute presentation. So basically like we're kind of in the process of progressing to a chronic glaucoma. Or it could be basically acute pressure spikes on top of like a long-term disease. Or there probably are other explanations for why there may be overlap between sort of acute and chronic features of glaucomatous degeneration. But regardless, that's that case. And then, so the main thing so what do we call this weird sort of spindle to stellate proliferation in the vitreous accompanied by the fibrovascular tissue near the optic nerve head and often causing a neovascular glaucoma. And this is canine ocular gliovascular, COGS, canine ocular gliovascular syndrome. I'm not getting that right. So for some reason, my brain is not. Okay, good. Sorry, my brain was freaking out for a second for some reason. Canine ocular gliovascular syndrome, or COGS in dogs. So this is a really weird disease. I don't think we quite know why it happens, but it tends to have this glial-like proliferation, usually in the anterior vitreous, although this one was kind of forming membranes that were going places. And then we usually get these eyes if they develop a neovascular glaucoma later. In this case, there was the additional feature of goniogenesis as well as fibrovascular membrane formation. In this case, because there isn't really like a huge amount of fibrovascular tissue in the angle, the glaucoma may have been more due to goniogenesis than acquired changes, but it's another one of these cases where I think because there's overlap of different things inside this eye, it's difficult to tell exactly what caused onset of glaucoma, which may complicate prognostication for the remaining eye. So just kind of an interesting multifactorial case. So there's that. Any questions about that? Okay. All right.
What breed was that?
That was a French bulldog. Okay, so the next one has quite an interesting gross photo. So this is a 10-year-old spayed female Chihuahua mix. And as you can see, this is quite a large eye for a Chihuahua mix. You can see from this measuring tape on the side. And then here's a front view of that eye before it was sectioned. We can see this really widely stretched palpebral fissure. The eyelids are still on this globe and sort of stretched to the side by this really enlarged structure here. Although probably this is where the cornea is at of that globe. So this is kind of just the globe, and then the rest of it is all tumor. And you can see that better on the hemisected view. Here's the globe here, which is just sort of sad and smushed off to one side. And then there's this rather large tumor in the orbit of this dog. It's a very interesting looking tumor. It's got this sort of translucent white-gray tissue as a predominant feature, and then lots of large dilated blood-filled spaces and a very necrotic center. This tissue in the middle is all necrotic. So that's what we have here, and we'll take a look at the histology. So I'll just briefly show you, or try to show you, a subgross view of the full eye, just because I think the smaller section of tumor that we have is better preserved, and I don't know. I can only do it 4x. Yeah. So here's our little smushed eye. You can see already that there's some significant corneal disease, which is probably basically exposure-induced corneal disease. This eye was very exophthalmic, and the palpebral fissure was very enlarged, and probably this animal was not blinking very easily over all of this. But the main event being this tumor that is causing that exophthalmos. And then we'll switch from here to the smaller and better preserved section. So here's just a smaller slice of that tumor. Just showing you the edges, and we're going to look around. So we're already seeing some very mineralized tissue in the middle, which is sort of chipping out because someone probably didn't decalcify it well enough. Me. But we also have this stuff that is embedded in the tumor cells, and it's some of the most frequent stuff that the tumor is producing. And looking at this closer, the exposure is kind of a little bit weird, but this is sort of a pale basophilic in this case tissue, and it has these cells embedded in little lacunae. So just as Gillian was showing earlier in the back of the sea turtle globe, this is again cartilage. So this tumor is making a chondromatous matrix, and the neoplastic cells are embedded in it. And you basically have to take my word for it, because I'm not going to spend a really long time searching around the entire thing with you. But this is the most frequent, basically, matrix that this tumor was producing, although it was also producing bone. And maybe we'll walk a little bit towards the mineralized areas. It's going to be too hard to tell, but some of this mineralized stuff was bone, where it was better decalcified, probably easier to see. And then the neoplastic cells themselves, let's find a reasonably well-preserved area and drop in on that. Maybe I should have just stayed where I was at. They tend to be sort of spindle to maybe sort of polygonal or rounded polygonal, and they're fairly pleomorphic. We had a good number of mitotic figures here as well. And I think with the exposure being what it is right now, it may be difficult for me to show you, but along with the cartilage and the bone that this guy was making, there was frequently brightly eosinophilic material interdigitating with the cells, which was osteoid. There's this tumor. They also, I will reveal, remarked on this case with CT scan, and the CT scan showed a polyostotic aggressive mixed osteolytic and osteoproliferative lesion in the medial aspect of the left orbit with early stages of perforation of the cranial fossa. So this, based on CT scan, was a tumor that was going places and producing a lot of bone and cartilage, and pretty aggressive in the head of this dog. Interestingly enough, the sections that we got with the globe had a fairly sharply demarcated border in a lot of areas, and we didn't see any areas of incomplete excision, but given the CT results, I would expect that this was probably incompletely excised, and they were expecting it. The differentials that we gave for this case are here. Probably the most likely differential would be an osteosarcoma, and then you can usually name the osteosarcoma based on the predominant matrix that it's making, because a lot of osteosarcomas can make all sorts of different things, but you kind of pick which one is most prevalent. So this would probably be a chondroblastic osteosarcoma. I mean, that said, calling osteosarcoma one type of osteosarcoma or another generally doesn't really make an impact on prognosis. Osteosarcoma is typically readily metastatic and can be quite locally aggressive. So the prognosis is kind of the same, whether it's chondroblastic or osteoblastic or whatever you want to call it. We also did differential, one of our visitors suggested, and I definitely came around to the differential of basically a poorly differentiated or a high grade, although the grading system isn't necessarily widely used, multilobular tumor of bone. Also a possibility, especially given the location, and at least based on our section, given that it sort of looked like a ball of tumor at the back of the eye. So that is that. Any questions about this case? Okay.
Right. That's some clinical photos for you. From this 11-year-old male-neutered Labrador Retriever. With a history of that for the owner, at least, that the dog had this pigmentation here dorsally on the left eye that had been there for like years. And it was unchanged basically until September of this year, when the dog went into the ER for acute squinting and discharge. It was started on some neopolydex in both eyes and had minimal improvement. You can see like the episcleral injection. You can also see a lot of pigment around the eye as well. A few days later, at recheck, it did have a diffusely blue cornea, so corneal edema, with the melanin pigment tracking within the anterior chamber, and it also had glaucoma at that time. The dog was placed on dorazolamide and timolol, and the pressure returned to normal, but did not regain vision. So the owners elected to enucleate. Other medical conditions, he does have some variable subcu masses. In his recent blood work panel, CBC Chem UA had no significant findings. And the owners declined doing any extra imaging. Grossly, we could see the pigment in the dorsal limbus there. We also noted that the iris and ciliary body in the choroid were kind of subtly thick. And then when we did some more trimming of the globe, that the iris and ciliary body base kind of laterally in the eye was pretty thick. And let's see, the vitreous was liquid and the retina was detached grossly as well. So let's take a look at this still. And we can go full screen. Thank you. All right. All right. So here we've got our cornea. Here's that limbal pigmentation here. It's a very discrete mass. But we can also note that the uvea is kind of thick and very, very hyperpigmented. And maybe even a little bit distorted. And here's our gonio slice, our extra slice of the globe. Again, lots of pigmentation, and then kind of a mass-like lesion forming here off the ciliary body plica, which we'll look at some more. Our retina detachment, there was also pigment kind of extending back into the optic nerve, and grossly we also noted that there was multifocal pigmentation along the posterior ciliary arteries as well. Here's more thickening, and then our retinal detachment, and then fibrovascular membranes galore. Right. All right. Oh my. Okay. All right. So we'll start back up here with our limbal mass. It's a nice, very discrete mass of very heavily pigmented cells, mostly polygonal, but occasionally a couple of the spindle cells. We looked at a couple different sections for reasons that I'll go into in a little bit, but there was really no connection between this mass and the inside of the structures inside the globe. Mitotic index wasn't really seen, no mitotic figures in this area, and pretty kind of benign looking cells. So we ended up calling this a limbal melanocytoma.
They have to trust this because microscope is not gonna.
Yeah, the camera.
Yeah,
can't deal
it's
with it.
not dealing with the pigment super well.
Try to deal with that.
So again, as I pointed out on subgross, there's a lot of pigment here with polygonal cells also that kind of distort and expand the uvea, and it goes all the way around. So this dog also has a component of uveal melanosis.
Keep that low magnification, yes.
Yeah, I think that should be okay. So again, the heavy pigmentation that goes all the way around in the uvea starts to distort it a little bit, pushing it over from just heavily pigmented into a uveal melanosis category. And then, as I said, we were starting to see this sort of mass formation here in like the ciliary body. And it was, figure this out. Can't really see the cells very well, but these are kind of more polygonal cells that are not pigmented, and they're forming a bit more of cords and trabeculae.
I go higher. See if they-
Yeah, and that area, I
And-
think it would be,
and-
yeah.
Okay, thank you.
Just the contrast between like
For
the
a
white
second.
background
Yeah.
and the black. It is.
Just flip back and forth a bunch of times.
Yeah.
Yeah, we'll get a chance to see it.
Okay. Oh my goodness.
Okay, size.
Apparently. So we were very suspicious about these cells in here, which is another reason that we went and got deeper sections. We were also suspicious about kind of the expansion of the uvea, especially since we noted that it was a little bit more thicker and maybe mass-like in other areas. And I will show you some deeper sections and we'll go over that. But I'll just stay here and sort of go over a couple other features first. So again, we've got a fibrovascular membrane coming over the front of the iris and extending over here through the pupillary margin. It's got a lot of hemorrhage in it. There's the retrocorneal membrane formation as well. There is some cataractous change in the lens. We also have some nice asteroid bodies in the anterior vitreous, so some asteroid hyalosis. And retina, again, is detached here. And then again, with our pigment sort of heading out in the back of the eye here. Let me show more here. This will be okay. And so as we did a couple deeper sections, we noticed that we started to get a more mass-like lesion in the ciliary body. Of the same heavily pigmented cells, mostly polygonal, but there is a spindle cell component to it, so it's a double population. These lovely areas here are areas of necrosis kind of lined by macrophages. So it's forming a little bit more mass-like lesions. So we also have a uveal melanocytoma in this globe. And then, and you can see that sort of tracks along the fibrovascular membranes. And then we were seeing more of these other epithelial cells forming trabeculae and stuff in here as well. And this portion is more consistent with an iridociliary adenoma. So there was also a collision of that tumor in here as well in this eye that already had plenty of other reasons. to be enucleated. All right. And oh my goodness, there was a lot. So interestingly, with all of this pigmentation, back, I'll show you what we did for our diagnoses. All right, so this was a heavily pigmented eye with sort of atypical stromal pigmentation, like I said, going out the optic nerve, kind of around the globe in the conjunctiva. That is called oculodermal melanocytosis or nevus of Oda. These dogs often have a lot of melanocytic tumors, as was evident with the anterior uveal melanocytoma, the dorsal limbal melanocytoma, and the uveal melanosis in the eye, and just a happenstance for an iridociliary adenoma that was also present. That was just a fun surprise thrown in there. So we have seen, I guess, some of these dogs also have differences in their pigmentation in their fur color in their head, where sometimes they will have a very distinct line down the middle of the head on the affected side, where it's a little bit more hyperpigmentation and darkly colored. The clinical photos, when this black lab, it was all the same color. Clinician noted that the dog didn't have any other pigmentation issues on the fur, but I guess I wonder, given how dark and that the dog is normally, if it would be as obvious. I think the pictures I've seen have been like more tan colored fur. You can see like it's just darker tan on the side, which I guess is common in humans to have like skin pigmentation, hyperpigmentation on the same side of the affected eye.
Yeah, we also didn't get a good image like face on, so it's possible to be seeing both sides of the dog's face.
Yeah.
We may have could maybe
Dark and darker.
Yeah, dark and darker. Yeah.
or yeah, maybe the skin itself with the
Right,
would have been
not just
pigmented.
the hair.
Mhm.
Or we're wrong about the diagnosis and it just has the ocular stuff but not the cutaneous. Like
Right.
yeah, it's I don't know.
So just kind of a interesting case with lots of things going on there. Okay. All right. Next up, I got a 16-year-old neutered domestic short-haired cat that came with a history of a slowly infiltrative cream to red intraocular mass within the anterior chamber. And then it had recent full thickness corneal rupture. This is the right globe. The left eye was normal. This has been going on for greater than 6 months. No evidence of glaucoma. The cat is an older cat that's indoor-outdoor and does receive epimedrol injections for IBS, inflammatory bowel syndrome. And the clinician was wondering about a possible history of trauma or potentially ocular manifestation of systemic disease. Talk about the eye that's up here. Okay, so we've got some third eyelid and the eyelid still attached to the globe. That's what's coming off here. And so here is the rupture that they were mentioned here, and you can see that the anterior chamber and the vitreous and everything else is just filled with this tan solid material. Kind of it goes over here. Got lots of hemorrhage in the eye as well. And we couldn't really tell what was going on with the retina or the optic nerve head, but it's probably just effaced by what's going on in the globe itself. So let's take a look. Beautiful screen. Okay. Now it's an extra fun case when your slides come marked with blue dots or any other color dots. So So here is our third eyelid. And here is our globe. There should be sclera here, but it's discontinuous, and you've got all of this mass-like tissue coming out of it. This is the cornea, somewhere in there. And then all just filled with this material. And again, can't really tell where the retina is. And here's our optic nerve at the back. All right. Here. All right. Cornea up at the front. Here is our rupture site. Got a couple of pigmented cells in here that used to be maybe where the iris was. Here's our ciliary body coming out here. And as just jump down into it here. Ooh, maybe. All right. So the infiltrate that is in here is just numerous macrophages and neutrophils. So it actually ends up being an inflammatory infiltrate. And since, oh my goodness. And as we cruise around, especially by these blue marks, we start to see these organisms here that are kind of a little bit larger. These ones kind of form a nice little ring. And I think it's because the structure that they're normally in is kind of ruptured. So I'm going to go for a hunt here and find you some more of those organisms. No. All right. So we have these like 30 to 80 micron in diameter round yeasts with this nice couple micron thick wall and some basophilic internal structures. Here we go. Here's a couple more. Got nice little like probably endospores in here. So this organism is consistent with Coccidioides. So pretty. All right. So again, this infiltrate is just sort of everywhere. It's this might be leftover retinal tissue, but it's probably the retina is probably diffusely detached and just effaced by the inflammation and the organisms. There are some more. And again, here is our scleral rupture. And so this inflammation is coming out into the episcleral region and into the conjunctiva. The cornea here is really kind of thick and also inflamed. We don't really see Descemet's membrane on this side of the eye, but it can pick it up starting over here. So it is ruptured. And possibly maybe it went out through the rupture and maybe it's hanging out somewhere else outside the cat. But there's also this nice little island of probably corneal epithelial cells here as well. So an epithelial inclusion cyst to go along with this. There's also corneal epithelial hyperplasia. Here we've got kind of a little cleft here beneath the epithelium, and it's kind of getting hyperplastic and maybe a little loss of polarity. So like a subepithelial bulla forming, probably from exposure. Yes. So just intense inflammation with the organisms consistent with Coccidioides. And usually this is a systemic disease. So probably starting in the respiratory tract and spreading out to the eye and other organs, liver, kidney, spleen, bone, CNS, heart, basically wherever it kind of wants to go. So we definitely said, you know, maybe try to look to make sure if there's other systemic infection with this organism, which was one of their differentials. We did wonder if maybe being on depomedrol, depending on the dosage, if that could have made the cat immunocompromised for this infection. And was able to tell them no evidence of neoplasia in this really old cat. And fun fact, the cat is also from Arizona, so that fits nicely with the Coccidioides. And just a pretty cool looking cat and species. So, and that was all that I had. Was there an extra case or was extra case if you want to do it?
I can finish up over there, I guess, just. It's won't be time to present the whole thing, but we might go. Yeah, thanks for joining us, everyone.